Hi, my name is Jasmine. I'm a nursing student at JCTC. I'm doing this little mini baby lecture, not as great as Jenny though, on epidurals. Um, Teaching helps me learn, and I said instead of talking to my stuffed animal, I will talk here, post it on YouTube. So let's talk about epidurals. So what do we know about epidurals? I'm gonna move this up a little bit. Okay, so these are advantages, but let's talk about it for a minute. There's more advantages, but an epidural is a pain reliever, okay? It is an infusion of an opioid analgesic into the dura in your spine. The advantages, now stop. It can be used for C-sections and vaginal deliveries. Um, let's say the mom is her pushing effort is really poor, um, because maybe she's having hypertonic contractions. That takes a lot of energy, okay? And she's tired, okay? So we're gonna say, okay, we're gonna give her an epidural. If she has a C-section and she has other conditions like preeclampsia and her blood pressure is really high, the baby's not descending. We've done every measure we can take. We've given her uh, a back balloon. We did cervical stimulation. Nothing's working. So then a doctor might suggest an epidural. Um, Now, the advantages of an epidural: pain relief, okay, and also it decreases the mom's pushing effort if she's really struggling to get the baby out of her vagina. Okay, it's very stressful. Um, Another benefit of an epidural is the baby. Okay, we're not just talking about the mom's benefits, but the baby's benefits too. Another benefit with the baby is that you have a decrease in side effects with an epidural versus with an IV opioid, like the four major ones we talk about in lecture: Statol, Demerol, Nubain, and morphine. Okay, way less side effects, and definitely way less side effects than general anesthetics. Okay, now let's talk about disadvantages. Write them on the board. Okay. Cheer up. So, disadvantages of an epidural, because every good thing has some bad stuff. The first thing I want to talk about is headaches. So, headaches. They don't seem as bad, but epidurals, they're horrible. Okay. Um, Now, a headache can occur because of an epidural due to what's known as posterior punctures. And those punctures happen when the anesthesiology is putting it in, and it has these little notches that tell them how far. But let's say the mom moved or something and something happened, happens. He pushed too far, okay, and that can cause a headache, because he wasn't supposed to go that far. So what we can do as nurses, first of all, we're gonna probably tell the anesthesiologist what happened or her symptoms. There should be an order just in case this happens, but if there's not, please tell the anesthesiologist before you do anything. Um, but things that we should know that we can do before he even puts it in the order. Caffeine, great. Caffeine relieves the pressure in your ventricles, like great. Because I know just for regular people, if you don't have caffeine, you get headaches. Caffeine is really good for headaches. Another one would be a painkiller. The situational and depends on what's in the orders. Okay, you can't just be giving out whatever painkiller you want. And also, they may do a blood patch. So what the blood patch does is like a fix a flat, basically, in your back. So what it does, I don't know any way to compare it to. It's like a fix a flat. So the blood patch, they put the little blood in there, it coagulates, boom, no more pressure. Okay. Another disadvantage is hypotension. When you give someone epidural, they get hypotension because there is no blood flow from here to here. It's gone. Okay, your blood pressure is low. Okay. Another disadvantage of epidurals that is great, but also bad. That is this pushing effort. So we gave it to her because she was having a hard time pushing, but at the same time, now the pushing effort has decreased drastically. So if she's not pushing, the labor is going to be long. It's going to be a slow labor. Okay. Now, so what's happening on the inside with the baby? That descent, that fetal descent, the change stations isn't happening as fast. Because why? She doesn't feel the urge to push anymore, okay? And with our help as nurses, when we're monitoring her strip, when she has contractions, we can tell her to push. Okay. That's part of our things that we could do. Um, Another thing is that epidurals cause pain, acute pain. Okay. So acute lower back pain is a big one. I will say that I had a C-section and I still have back pain. Even though they told me it's gonna be temporary, Jasmine, they lied. My back still hurts. Uh, Another thing is that you have movement restriction. You can't move. So, right, it's movement restriction. So, because you have a loss in sensation from here down, you can't really see me, but from here down, um, you can't feel your legs. The mom can't feel her legs. Let's say, talk about mom. Talk about me yeah. That's what they told me. And that's what Jenny said. So you're not going to be able to feel your legs. So because you can't feel your legs, safety is a priority. She can't get up and go to the bathroom like she would think she could, but she can't. We're probably going to give her, or more than likely, going to give her a straight calf. And with straight calves too, she's going to have bladder retention. Just a little bit so you can see it. Because, well, not necessarily bladder retention, but just bladder delay. Let me put bladder delay. I'm sorry. Bladder delay because she doesn't feel anything. So our interventions before this happens is that we're probably going to give her a straight calf or a Foley calf. Now we know as nursing students that the straight calf, if she moves, is probably going to fall out. But with a Foley catheter, you insert it, you fill it up with normal saline. No matter how hard she moves, it won't deflate. We actually have to go in and get rid of that saline. We know that already. All right. So the next topic I'm going to talk about with epidurals is contraindications. So why would someone not get a epidural? The first one is obvious, right? The first one is she said no. We are patient advocates. If she says no, it's no. It's a no go, bro. Can't do it. All right. The second one is if she has some type of blood coagulation problem. That is big, 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 big. Because if we puncture her back, or she has a platelet problem or some type of congenital disorder, and we puncture her back, she's going to bleed out. So, blood coagulation disorder, big. Speaking of congenital disorders, some type of spinal congenital problem. If she has a spinal congenital problem, for example, or spinal injury, I'll put congenital too. Because, for example, if the mom, excuse me, if the mom had spina bifida and let's say the doctor and we are supposed to check because nurses are responsible for everything, um, and he did it anyway, she might end up paralyzed and we might lose our license. There are only a few exceptions to that. I know someone who had spina bifida and she was able to get a epidural, but not every woman is as lucky and as blessed as my friend is. So, want to make sure that we do a very thorough history check with that. Another one is if she has, since we're blocking sensation, okay, that in turn naturally increases your intracranial pressure. Okay. So if she already has some type of intracranial pressure increase problem, no epidural for you. So now, uh, and let's say we see our patient every day. We see her, she's probably gonna be in hospital for at least 2 to 3 days. Um, and we know her allergies. Okay. If the anesthesiologist doesn't check if she's allergic to that type of opioid or painkiller, we're at risk. Okay, so we have to make sure that she's not allergic to whatever that anesthesiologist is putting into her body. Okay, we are a patient advocate. Allergy. And the last one is, oh, there's two more. One of the other ones is hypovolemic shock. If she has a history of that, no epidural. And the last one, which is really important, is that as the anesthesiologist is putting that in, and maybe it's a nurse. Nurses know better though, because we're smart. Uh, but let's just say, because pain nurses can do certain things too. But let's just say, we turn her over and she's about to get it in her back, and we do our assessment, our thorough assessment. We look at her skin. Her skin looks like there's an infection at the site. We're not going to give her an epidural at all, okay? Because if that infection gets in her bloodstream, we know that infections in the blood can cause sepsis, and we're not about to do that, okay? Especially, let's say she had preeclampsia, it'll make it worse. So, infection at the site. All right. So, go over this again. Contraindications are if she says no, blood coagulation problems, platelet count, spinal injuries, congenital problems, increased intracranial pressure, an allergy to that pain medication, because lots of people are actually allergic to more than what we think. If she has a history of hypovolemic shock, or if there is an infection at that site. Okay, the advantages of an epidural are pain relief, decreased pushing effort, and for the fetus, less side effects with opioids and general anesthetics. Okay? The disadvantages, headaches, which can cause posterior punctures, which are relieved by our three nursing interventions, painkillers, caffeine, and blood patch. Okay. Another disadvantage is because we have now decreased this pushing effort, the labor is slow. That baby is going to descend very slowly. Okay. Uh, Another disadvantage, lower back pain. It happens. We just put something inside your body. Another disadvantage is movement restriction and bladder delay. So we're going to insert fluid after. our nursing interventions. What we are going to do during and after placement. So, during placement, we are going to do an assessment. We have to get consent, okay? And we have to tell her this information that I just gave on the board, okay? Needs to let her know what's going to happen to her, the baby. Those contraindications should be in her history. We're going to do a thorough history check. So that's part of our assessment. So during placement, we're going to check consent, slash info. We are going to also make sure she has an 18 gauge in her arm. Oh gosh, 18 gauge IV. We're going to give her 500 to 1,000 ml bolus. Okay. We also need a baseline, not just for her, but for the baby. Okay. We're going to assess pain. There's such thing as breakthrough pain, but we'll talk about that in a minute. And we're going to have you placement. Oh, yes. During the placement, we have to make sure that the position she's in. So, when they give a mom an epidural, she either has to be on her side with her chin inside her chest like this. She cannot move. There's no moving. Okay? And the reason why they want her to bend down is because I wish I had a little skeleton, but it stretches out the spine. So the doctor, yes, is able to feel for the placement of the epidural. Okay. You can have her crushed down on her side doing that, or you can have her sitting, but you have to tell her she can't move. Okay. If she moves, he may puncture something else. She may get a postural puncture, a headache, or something like that. So we're definitely not going to move. Okay. Um, After placement, we're gonna first do our vital signs. And the vital sign that we are looking for, number one, is her blood pressure. Okay. And we're gonna assess the blood pressure every 15 minutes. Why? Because the BP, we learned this in fundamentals, is a emergency assessment. We just put a very powerful drug inside her back. So we want to make sure that her BP is stable because epidurals cause hypotension. Okay, so we want to make sure she's stable. They're also going to assess the fetal heart rate because what happens to the mom happens to the baby. Okay, and then we're going to assess too, because one of the disadvantages we talked about earlier was bladder distension. So after we're going to assess her bladder, and make sure she has a straight or a Foley catheter inserted. Uh, and another thing that Jenny mentioned is, like I said earlier too, we have to help her with pushing. She has no sensation from here down. I know you can't really see me that well, but my bottom half. She has no sensation. So when we look at the fetal monitoring strip, we really have, every time she's, like when she's in the second stage of labor, she's ready to push the baby out. She's 10 centimeters dilated. But let's say she's not. But she's still having contractions and we're trying to get the baby down. We have to look at those strips that tell us when she's having a contraction. So we can tell her it's time to push now because she can't feel it. But just because she can't feel it does not mean it's not there. Okay. Another thing that we need to be mindful of are those stirrups, okay? Those stirrups are those things at the edge of the bed that can bruise her legs, okay? And We're worried about safety too with that. But with an epidural, because it causes hypotension and she's not moving her legs, uh, the mother is at risk for clots. Okay. Now there are things that we can do as nurses. We can get an SCD and put on our legs to help with circulation and stuff like that. But we want to make sure that the stirrups are, it's not harming her every time she turns or she rotates. She should be left lateral though. Okay. And if she needs assistance to turn, make sure we're there to help her and stuff like that. Um, did I miss anything? No. Okay, so let's talk about breakthrough pain. Oh, wait, do I need to write this down? Probably right now. Right now helps. Okay, breakthrough pain. So let's say this is horrible. Whatever. All right, breakthrough pain. Breakthrough pain. So breakthrough pain is you're going fine, and now you feel full blown contractions. Okay, it may not be that intense, but you were good and now you're doing horrible. Now the mom's doing bad, really bad. Okay. Now you have to let the anesthesiologist know. Okay. Or whoever put it in. Okay. Um, because maybe, like I was mentioning earlier, the epidural has these little notches on it and it'll tell them how far to go in. So maybe it shrunk back a little bit and the medication is not getting into her, it's getting on the bed. Another reason why she might have breakthrough pain is the position. So maybe we need to change her position. But anesthesiologists could order sterile water, which is they put it in there. They put epidural in there and they put sterile water in there, and that provides like 60 to 90 minutes of pain relief temporarily until they get their supplies back together. But you definitely need, or you might get a bolus replacement. You know, um, yeah, that's it. Breakthrough pain. Just get it fixed. Tell the anesthesiologist. Um, Positioning. They may need to come fix it. The placement's wrong. Uh, the integrity is just off. All right. So now let's talk about nausea and vomiting. All right. All right. Nausea and vomiting. The problems with epidural. So although the mother has probably been on ice chips for a day or so, we're gonna have to give her an antiemetic. All right. And epidurals cause nausea and vomiting. Let me write this down. We can give her an antiemetic, like Benadryl or something. Or maybe she's nauseated because the infusion is too fast. So we can slow the infusion. Um, Another thing that epidurals do is that they cause respiratory depression. So we want to check her respiratory rate. So now, how to remember that is that it's still an opioid infusion with a painkiller. So it's going to cause respiratory depression. So we have to constantly check on the mom to make sure she's okay. If you're having a hard time remembering it. Oh my God, I can't spell today. Jesus. Respiratory depression. So we're going to do frequent checks. Okay, so, and normal respiration for a regular person is 12 to 20. For a pregnant woman, it may be higher. It may be 25 to 30. She's doing a whole lot more. She's breathing a whole lot more. However, if it gets below 12, you need to notify the doctor immediately. That's a problem. Um, Now, the potential problems with both epidural and spinal, which I'm going to get into in the next video, is both of them cause hypotension. Interventions that we can do to alleviate these. Where's my eraser? Okay, one of the things that we can do to alleviate these problems. So it causes maternal hypotension, spinal. So, and spinal and epidurals are called combinations or CSEs. So things that we can do, like I was saying earlier, we can first thing you want to do, ABCs. Give her some oxygen. That's administer oxygen. The second thing you want to do is slow that infusion down. Okay. The other thing you want to do is I apologize. I got confused. You want to increase your IV flow rate. Okay. That's what Jenny said anyway. Increase. Okay. So with maternal hypotension, spinal and epidural, you want to give her oxygen. You want to increase your flow rate, and then you want to put her in left lateral because left lateral increases O2. Okay. Left lateral, and the last thing you want to do is give her Epidural. Epidural. I do believe it's 5 to 10 milligrams. If the BP doesn't recover after you do these interventions. So with a CSE, sit down. Okay. Okay. Potential problems with epidurals, especially these two in combination. They will cause hypotension. Okay. So things that we're going to do to alleviate that: ABCs, airway, breathing, circulation. So airway, O2, breathing, O2, circulation, IV flow rate, circulation, left lateral. And if these do not work, then we're going to give her Epidural 5 to 10 milligrams. Okay, that should be in her orders already, but it may not be. So we're going to make sure that if it is, by the grace of God, it should be, that we're going to give her that. Okay? And I think that's all for epidurals. See you guys later. Bye.